Well, hi, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And thank you all so much for joining us today. We have a live webinar that I'm very excited about sharing with you guys today. And it is hosted by mPulse Mobile. And it is titled Improving Patient Outcomes with Equitable Health Journeys. And there's going to be a lot of good information in here. And don't worry, we're going to get you the slides after we're done. And I'll tell you a little bit more about that. But a few items of note before we get started. This is a traditional webinar format. So you don't need to worry about muting your microphone or you're turning off your camera or anything like that. We can't see you or hear you, so don't worry about that. But we do want to hear from you during the webinar. So you'll be able to submit questions to our presenters at any time throughout the webinar using your control module. And there's a little place for questions on there, which is different than the chat. So make sure you submit your questions there, but you don't have to wait until the Q&A in order to do that. So at any time, go ahead and do that. But we will have time for some Q&A. If we don't get to your question for some reason, don't worry, someone will follow up with you via email afterwards. So even if we're just wrapping up at the last second, go ahead and ask your question. We'd love to answer it for you. And then finally, today's session is being recorded. So what we're going to do is after we're done today, I'm going to let the video process, and then I'm going to send everybody out a link. And there will be a where you can watch the recording from today's session, also where you can download the slides, interact with the team. So there'll be a lot of information there. And we hope that you would, rewatch it, share it with colleagues and friends. And yeah, we're very excited to have you today. So without further ado, I would like to introduce very briefly our presenters today. We have Srivani Ganti, and she's the Director of Health Equity, and also Christian Baggy, who's the Vice President of Digital Engagement Strategy and Development. So I believe Srivani is going to kick us off and go through the agenda. So welcome.
Thank you so much, Garrett, for having us. Oops, of course, advanced too early. I'm sorry about that, but thank you everyone for joining. So quickly, wanting to go over our agenda, we have a lot of exciting details to share with you today. So first, we want to give you a baseline intro. Who are we? Who is mPulse? Why are we here? What are some common barriers to entries that your patient may be experiencing? And of course, what is health equity? What are the costs of ignoring it? How can digital innovations create access? And of course, in conclusion, the impact of equity and the work and the power that it can have. So I'm going to turn it over to my friend Christian here, who's going to tell you a little bit more about mPulse and what makes us qualified to even be talking to you today.
Thank you, Srivani. If you want to go to the next slide, who is mPulse? It's almost like we practiced that before. You teed me up really well there. So, mPulse is a multi-channel digital engagement company, and we've been focused on servicing healthcare clients for going on 13 years. So what that means is that we have a long history of doing digital outreach and creating campaigns and programs that have a wide variety of health plans, as well as ACOs, MSOs, and any other acronym you can think of, use to communicate to their patients and members. The value of mPulse and what we've been doing is because we've been doing this for so long, we've learned along the way about how best to engage folks and get them to take action, whatever that action might be. And not only do we have the scripting and the content, which Srivani is a big portion of creating that, we also have the technology. So, when you combine everything together, what you end up getting is really impactful programs that make a difference, that change behaviors. And as you can see from the slide here, we've worked with a lot of different partners. We only work within healthcare, so we're not one of those companies that do texting for financial services or anything like that. We're 100% focused on this. And through the 13 years of doing this, we've captured lots of different clients. We service over 200 different health entities currently. And last year, I think we were well over 1 billion different touch points in our engagement. So we'll speak more to that in a little bit. But working with a partner that has been doing this and knows the space and knows what it is that is going to motivate and engage your members and patients is super important. So if you go to the next slide, you might say, hey, Christian, that's great that you're doing all this engagement, but how can you back it up? And we can definitely back it up. We have tons of different case studies, and one of the big things that I focus on when we look at that is unique engagement. So, you know, when we look at the different lines of business that we work, we craft messages specific to those people within that line of business. So if you have a Medicare population or a Medicaid population, we know the ways in which to engage them. And so if you look at the slide there, you're going to see different engagement rates. Now, these aren't totality engagement. We're not, you know, looking at the number of messages sent and the number of replies. These are individuals that respond within programs. And that's super important because you want the individual to not only receive your message, but to take action. And when you look at us compared to a lot of others out there, we far exceed typical engagement rates that are done either by live agent or IVR or any other channel that you might use. And we have really low opt-out rates, which are basically people saying, hey, stop sending me messages. So when you dive down a little bit deeper, you know, into the sort of the process that we do, we actually go to campaign specific levels. And, you know, we're going to talk specifically on health equity today. And that's, you know, an undercurrent in just about every campaign that we run. We have a lot of targeted campaigns that our ACO and value-based care organizations use us for. And, you know, up here is just, you know, some numbers where we had a control as well as the mPulse, and you can see the results that we drive. So, you know, this isn't meant to be a product pitch per se, but this is meant to give you guys an idea that, you know, we know what we're doing. We've been doing it for a long time and we're really good at it. And I think, you know, as we learn more about health equity and the importance that CMS among other organizations are putting on that, you know, you're going to see more of that in the program and following below. So with that, I think I'm turning it back to you, Sravani.
Thanks so much, Christian. So let's dive into the problem. And I apologize if you can hear my dog. She clearly scheduled this on her calendar. I apologize. But so the question is, why are only 8% of US adults seeking preventive care? What's getting in their way? Well, there are a number of reasons for why they may be not receiving preventive care visits, but here are some that we've encountered at mPulse. An easy one is if a patient feels healthy, they simply don't see the need to go into their appointments. Health deserts are not uncommon. Some patients may not have easy access to urgent care, hospitals, let alone primary care providers. If they do, sometimes they can be a strained relationship, making them potentially unwilling to seek care. There's also a great sense of fear and anxiety when going to the doctor. Patients may be fearful to reveal underlying conditions that they then must deal with that can also be costly. And in addition to poor access, gaps in education, structural inequities, biases, and other barriers, these all just get in the way and compound themselves to prevent individuals from seeking preventive care. So Christian, I'd love to know, in addition to these, have you encountered any other barriers in your conversations with other ACOs?
You know, I think as you look at barriers, I mean, everyone's different, right? So every individual has different issues that they're dealing with within their lives. You know, a lot of times, you know, it might be a cost thing. It might be, hey, do I have transportation to get there? You know, I think one of the good ones here is like, you know, I don't need it. You know, I don't think I need it. You know, those barriers, they happen all the time. And, you know, I think it's really interesting that you're bringing this up because how do you deal with it when you do find a barrier?
Yeah, absolutely. And when you have these barriers, it can kind of feel overwhelming. You don't know where to begin. But honestly, I think there is something that we can do. And I think that's something we really leverage here at mPulse, and it's digital outreach. We know that digital outreach can bridge the gap between the patient and provider relationship. And when it comes to tailoring a patient journey, it doesn't need to be that hard. To begin with, we know that 97% of Americans actually have a cell phone of some kind, with 85% of those being smartphones. And that gives us an incredible opportunity to leverage scalable, lower cost digital modalities. Now, like Christian just said, no two people are the same, no two patients are the same. So we need to take that in consideration when we're designing these patient journeys. Even if they present the same condition, weight, gender, their life experiences ultimately shape who they are and can truly impact their health outcomes. And I know this is a lot to take into consideration here. So where do you even begin? Well, for us at mPulse, we really like to look at whole person health. And our in-house engagement and content team really designs solutions by tailoring them and personalizing them by leveraging behavioral science, learning strategy, and health equity. So we understand that there are behavioral barriers and challenges that every patient faces, but we also empower them through our captivating learning strategy, and we overcome barriers in trust, we addressed health literacy with culturally relevant messaging powered by our SDOH index and high impact content. Plus, we're able to support 150 plus languages. And I know that's really exciting, but I would love to talk about all of these all day with you, but I know we're here to talk about health equity, one of my favorite areas. So I want to tell you, how can we jumpstart patient journeys with health equity in mind? But before I start that conversation, let's all set the stage here and define what is health equity. Well, per the CDC, health equity is a state in which everyone has a fair and just opportunity to attain their highest level of health. And while it can feel really aspirational, and I mean really, really aspirational to address health equity, there's honestly a true economic cost to ignoring it. It's estimated that ignoring health inequities will cost the US $1 trillion by 2040. And when it comes to treating chronic conditions like asthma, cancer, and diabetes, it's rising to $320 billion in healthcare costs. But those costs are only exacerbated further because of delays in diagnoses in racial minorities. And then in addition to that, when you're not feeling well and you have all these health inequities, you have more people calling out sick, which is resulting in $42 billion of productivity loss. Now, these numbers are ominous. There are too many zeros, in my opinion, associated with all of them. But the Urban Institute estimates that we could save $15.6 billion. I know these are a lot of numbers that I'm throwing out here, but the reason why I was doing that is that sometimes we can think about health equity as a little bit of a nebulous concept. And there is a true cost to it, but there's also a true opportunity to save, and that can go back into reinvestment in patients and communities. So now that we're understanding the economics of it, I'm going to ask this question again to everyone, hypothetically, of course, but where do we begin? So as Christian and I have been talking about, we at mPulse, we really excel at leveraging our platform to create meaningful programs that connect with patients. When it comes to designing our programs with health equity in mind, we've identified 4 key challenges. The first one being health literacy. We want to support a patient's need to find, understand, and use health information. Accessibility. We want to remove barriers that keep patients from accessing health information and systems. Social determinants of health, something that we're also hearing a lot about in addition to health equity, where we want to address the social, environmental, and economic factors that shape health outcomes and experiences. And last, cultural competency. We want to respond to and respect the beliefs, practices, and needs of a diverse population. That is what the American landscape is. It's an extremely diverse, rich tapestry, as we often hear. So we want to ensure we're addressing these all in a meaningful way. Now, I want to caveat and note that there are many, many more challenges when it comes to addressing health inequities. And we identified these 4 challenges as ones that we at mPulse can address meaningfully through patient engagement. But of course, with challenges, how do we approach them with authenticity? One of the big things that we thought about at mPulse when we were developing this health equity strategy was ensuring that we weren't being too buzzwordy, but we were also really rooted in truth and outcomes and making sure that it was something that was tangible that we could apply. So we came up with these methods. And our first method is compassion. Lead with kindness and empathy. It's one of those real baseline things that we're taught in the early years of school, right? One of our favorites is data. Data is the best way we can really jumpstart patient journeys and ensure that we're actually connecting with the member in a meaningful way. Respect. Aretha sang it beautifully, right? We want to treat everybody with dignity regardless of their backgrounds and beliefs. Inclusivity. When we design for one, intentionality. I got ahead of myself there, I apologize. Intentionality. We want to design easy to use programs that bust down barriers and ignite action. Now, inclusivity. When we design for one, we benefit all. We need to listen, learn, and evolve. That is so incredibly important if we want to truly and meaningfully address health inequities. And last is simplicity. We want to communicate with clarity, use clean design and plain language. So when we approach these challenges with our methods, we ultimately can address health equity and patient engagement head on. By addressing these core challenges of health equity with our targeted methods, we're removing barriers to drive gap closure. And I think you saw that earlier with the results that Christian presented. We're doing some meaningful change that are really important in connecting patients with what they need to do. But we're also committed to continuing reducing disparities and inequities. We're always designing our programs to be relevant and relatable and ensuring that we're addressing the diverse communities that you are serving. And of course, we want to also design our solutions with patients in mind. They all have different backgrounds, they have differing abilities. So we want to create that true tailored experience for them. And I know I can give you all of these nice examples, but I want to give you an opportunity to show what a patient journey could look like when we design it with health equity in mind. So this is Thara. Thara is generally healthy and she's in her 40s. She doesn't really see the need to go to the doctor, especially if she feels fine. Plus, she doesn't have a car to get to and from appointments. So when we're thinking about Thara, we can see that there are clear gaps in education and transportation that we can easily tackle through digital channels. We can start by sending her actionable text messages that inform her at a baseline. We also make it really easy for her to make an appointment with her provider by putting that phone number directly in the message. But then we can also continue to close the knowledge gap by using videos from our high quality streaming health education library that shows a scenario similar to her own personal experience. And then of course, the biggest one is informing her that transportation services are available to her, right? We want to remove that significant barrier. And something else that we like to do, as Christian mentioned earlier, is cost is also a common issue when it comes to patients. They're always concerned with how expensive something is going to be. We know healthcare can be exorbitant in terms of costs. So we often like to take opportunities to call out no cost whenever we can, because then that can remove a barrier inherently for the individual. So when we take into consideration Thara's health equity challenges, we leverage our methods and our proprietary strategy, we're able to get Thara to make her much needed preventive screening appointment. Now, I know this is only one patient experience, so Christian, I'm curious if you could share what a multi-channel patient journey might look like for different individuals.
Sounds good. So one of the beauties of working with mPulse is that we are not a one-trick pony. So we do try to drive folks in the channel that most is going to get the best results, which is typically the SMS. But we realize that when you look at your patient rosters, you're not going to have a cell phone for everyone, right? So what happens when you don't have that? We are a multi-channel, so we're able to deliver messaging, whether it's through email or a landline. And one of the first things that we do is we will actually take in the phone numbers that you have and we'll scrub that to figure out how many cell phones you have and how many emails, what's the percentage of landlines. And then we'll base our programs, off of the information that you have within your patients. So, dependent upon which channel they fit into, and we can do multiple channels when needed, they receive a journey, and the journey can be specific to whatever it is that you're looking to drive them to do. Set up an annual wellness appointment, get a gap in care closed, stop going to the ER when you can go see your doctor, right? Things like that. And then, using that same sort of methodology that Shravani just spoke to regarding Tara, we build out these platforms and these programs that will drive the result. And as we do that, we're delivering the health equity information, we're breaking barriers, so on and so forth. But the fact that we've done this for so long, the fact that we've walked and now we're running, is the value that we bring a lot of times, is that we know what's going to work, and we know how to drive engagement as well as that, and regardless of the channel. So if you move on to the next slide, I think I do want to talk a little bit deeper dive into some of the success stories that we have. And this one's more of a high level overview, but as Shravani said earlier, a lot of the outcomes that happen are not medical related. It's the socioeconomic, health related behaviors, environmental. I mean, that's what really is driving whether or not someone, how healthy someone is sometimes. Knowing that, and knowing the fact that 97%, 98% have a cell phone, really drives, takes what we do and drives the value across the line for our clients. If you go to the next slide, we actually take it a step further sometimes, and we have something called the SDOH index. And what this is a mPulse proprietary data set of public and proprietary data that is out there that we use, and we basically are able to geolocate based upon the information that's provided on your patient file. So if I know their name, address, and zip code, what I can do is I can actually drill down into this data set that we have, which might tell me, the percentage of people that are living in poverty within, where that person lives, or non-white percentage, or even no high school. And that's important because we take that information and then we can really drill down onto the engagement and the scripting that we're going to be sending out to be empathetic, to, get into those barriers and break those barriers so they have, opportunity to get the care that they need. And so if you go on to the next slide, what you'll see is, the actual technology that's running this. So it's great that we're talking about this, and we're saying, hey, we can get you these results, but there is a great tech stack that lives below it. And, what we run on every program or the technology that's running in the background of every program, it has AI, where we're able to continue conversations in the channel that they're talking within. So, a text message doesn't break down, text chat doesn't break down because, for example, they said yep instead of yes. That's natural language processing that's running in there. We can do a lot of different things when we tie in that SDOH index. We can do a lot of things when we tie the technology together that for your consumer, your patient, who is ultimately a consumer, it gives them a great experience. Additionally, knowing that CMS recently came out, I think it's called the Framework for Health Equity, and they have 5 different priorities. The first being, collection, reporting, and analysis of standardized data. We can deliver, surveys, SDOH survey specifics. We can help build out your data set by engaging folks and using that technology in the background to get answers, that can be leveraged and pushed upstream as, what CMS is pushing down across both payers and providers coming. So using that information and knowing how we use SDOH, and that we have more, results on the next slide, which really speaks to, how we're able to optimize this. So, everything from prescription refills to ER deflection. When we are able to predict using the SDOH and then tailor that content, you're going to get better results. And I think the proof's in the pudding here, whether it's, the gaps in care, 48% of unengaged members completed screenings using this sort of framework. And so, we can go far and wide, and we can be really specific while we're doing it. And I think that's really important for some of you guys who have, large membership or patient populations and the like. So you want to go to the next one. I think this is the best part of what I do. So we are focused on delivering results, and we can do that in a way that, Shravani's discussed earlier regarding the health equity and being empathetic. But in the end, you'd be surprised if you send a text message. When we looked at unique engagement rates earlier, people do respond. And the responses are all over the place. But one of the best things about my job is reading the responses that some of these people send, because they are amazing. From extremely helpful, thank you, to always the good one here. No, thank you guys are amazing. Seriously, completely amazing. Like, people enjoy this. They enjoy the experience. And so, what we're doing here with this whole process is we're reaching people, we're hooking them, we're educating them, we're being empathetic, we're breaking down their barriers, we're continuing conversations. And what that means is you're getting the result that you want. So that person scheduling, that person attending, that person getting that preventive care. And we're doing it for these groups in the way that they might have been left behind before. If you use that really super generalized messaging that's not specific, those people that, don't fit the norm are going to be falling off the wayside. And so this is, one of the great things that we do here is not only do we get results, but people like engaging in this way.
Absolutely. And I want to just note that, as Christian is saying, people really do love seeing these messages. And when we add health equity and use it to jumpstart their journey, they're going to only love it more. People always fundamentally want to be seen. They want to be heard. They want to be validated in what they're dealing with, right? And when it comes to addressing health equity, it's fundamentally the right thing to do. I know it comes across as an industry buzzword. I know CMS is telling all of us that we need to address it, and we're trying to figure out how can we do it in a meaningful way. But it really is the right thing to do to ensure that we see equitable health outcomes. And just this is a really interesting stat that I had come across, but the United Nations High Commissioner of Human Rights and the WHO identified health as a basic human right as early as 1966. And the reason why this really resonated with me is that health equity is also part of healthcare, right? And so I really want to just have all of you think about how can we put health equity more meaningfully into the forefront of what we're doing, and how can we, at mPulse work with you to ensure that we're doing it in this meaningful and authentic way, leveraging these digital scalable technologies. So thank you so much to all of you who have joined us, and we're now, I guess, going to open it up for questions and answers.
So I think Garrett's supposed to come back and be our MC as far as the question and answer piece. We might have lost him. I don't know.
Well, let's see if there's anything in the chat. I'll pretend I know how to work this.
Hey guys, so sorry, my sound went out. I am back. Apologize for that. We are working live, folks, so these kind of things happen.
It's relatable.
All right, so yes, we do have some questions, and first of all, thank you guys so much. That was a wonderful presentation, and we do have some questions from the audience here. So now, if you have one, go ahead and ask it using your control module. There's a place for questions there, and we'll get to as many of them as we can. So let's dive in. Our first question here is, let's see. How do the insights you gather from different populations inform and optimize future programs you run?
So I think it's a really important form of insight, right? We're trying to understand what those behaviors are. So I think an example I can use that I commonly run into is with Medicaid populations. Transportation was often one that came up, and also wrong phone number was one that often came up. So as I was reviewing what members were saying, I would see this come up time and time again. And I'm like, okay, I need to adjust and I need to pivot something. So something as simple as like prompting the individual to text if it's the wrong person we've reached out to, really useful, because then they're indicating, and that's how we're changing that behavior. And then, like we said with Thara, a lot of health plans, a lot of ACOs, they have transportation services available to them. So we elevate that to the individual. We elevate that to the patient and say, hey, this is available to you at no cost. And we want to just use that as an opportunity that if like a couple of people are, say, elevating this, then we probably should take that into consideration when iterating on the next version of a program.
And I'll add to that too, just another piece. I mean, that iteration is so important. And that only comes with running many campaigns over a long time, right? So when I say we are, we have the best in breed as far as comes to scripting and things like that, we really do, because we've run the program multiple times. And some interesting things come out of it. Like, for example, like, when you think about Latino males trying and asking them to get a colorectal cancer screening, right? When you run an IVR and you're actually reaching out to them, if they hear a male voice, they're more likely to get that colorectal cancer screening done. Now, you might wonder, like, okay, well, that's kind of interesting, but when you think about how the Latino culture is set up, and it's very, masculine, they don't want to hear from a female voice, right? So it's taking little things like that we can embed, and then that optimizes the program going forward. And you only can get that through running, like I said, a lot of these campaigns, and the fact that we've been doing this for a long time allows us that data set that we're able to go back to and see how we can optimize moving forward.
And I also think it goes back to the concept of cultural humility. Like Christian just gave a really great example there, because like I myself, like I think about a lot of behaviors that I witnessed within my own family, my own community, and then through research that are often preventing them from seeking certain type of care, because there might be cultural beliefs and misnomers associated with it. Or just as something as simple as saying, eat healthy. And I use this example a lot because it's not a very good example that's very inclusive. With the populations that we serve, unfortunately, a lot of them tend to be food insecure. So when we say eat healthy, they are not going to Whole Foods and buying like beautiful lush greens. They
Right.
are taking their EBT cards, they're taking their SNAP cards, and they're making that stretch with their budget. And unfortunately, with the way the system is designed, the cheapest options are not always the healthiest options. So it's also taking a concerted effort and thinking about what this means. And it does require a lot of forethought. I think something that I feel is always so important for people to understand, especially the people we work with and like the customers, is that it might be a little text message, but there's a lot of thought that goes into it, led by our engagement and content team, because we might even overthink it because we want to ensure when we're designing for everyone on the margins to include everybody in the center.
Well put.
Great. Oh, that was wonderful. Okay, next question here is, what are some ways ACOs have leveraged your expertise to improve their outcomes?
So I'll take that one. There's a lot of things I could pull from, but there's three main things that I see a lot of ACOs coming to us and working with us on, and it goes a little bit outside the health equity piece that we're talking about there, but like when it comes to like preventing unneeded ER visits, for example, right, would be one, or med adherence and trying to keep people adherent as far as gaps in care go, and then obviously the annual wellness visit. Everyone is eligible for that. There's a lot of value that comes from driving that annual wellness visit, from the provider as well as to the actual individual that shows up when they present themselves. So it ranges quite a bit, but those are three major ones that we see more often than not in the campaigns that we run. There'll be those three specific ones.
Wonderful. All right, moving right along here. Next question is, where did your health equity strategy come from, and what helped inform it?
Oh, it's been a long process in development that has involved a lot of research, a lot of collaboration within the wonderful team members at mPulse. I think a lot of it also stems from the fact that all of us felt it's the right thing to do, but how do we take something that can feel nebulous and really aspirational and put it into something that's very clear and actionable, right? So why did we come up with those 4 challenges? Like I had noted, there are a lot of challenges facing health inequities, so we're not going to be able to address all of them. But we're experts in member and patient engagement. So we thought these 4 challenges of health literacy, SDOH, cultural competency, and accessibility were ones that we could have a meaningful impact on. So it's taking something that was like, it's working your way down, right? It's like taking one idea and editing to make it seem, to ensure that we're doing it in a way that's meaningful, because what I really didn't want us to do was say we're addressing health equity and then only have like one program that then just showed a bunch of diverse faces, right? Our team is very dedicated to the authenticity of it. It's why we have centered it as part of our like marketing efforts and like what we're doing in the future. It's like a huge part of our efforts, right? And when it came to kind of thinking about also the methods, we went back and forth on this a lot. Even up to yesterday, we were tinkering with it. We're thinking about like, how do we ensure that this is making sense for what we're talking about? And the thing is like when we come up with those challenges, it's like, those are some really big challenges. Like, how am I going to address health literacy in people who have continually lost faith in the medical establishment? Right? Like that's actually something that I think we've all unfortunately experienced with the pandemic, is the consistent degradation of trust within the medical establishment and how people digest their information. So how do we ensure that we can remain authorities on the behalf of the customers that we're serving, while also sometimes dealing with folks who frankly do not want to engage with us and they let us know? Like we shared all the really happy ones, but sometimes we see some very interesting responses to our messages. So we're trying to take into account, again, like it's going back to respect. While they may not want to hear from us, their feelings are valid and we need to still treat them with dignity to ensure. So it's like we're taking all these years of experience, we're seeing what's happening in the landscape, because the other big part is that within health equity, we cannot ignore what's going on in the world. So when we talk about it, we have to think about economic, climate, racial, gender, all of these types of justices, social, in order to actually inform the process, inform what we're doing, because none of us operate in a vacuum. Our healthcare does not operate in a vacuum. We know that many of our patients are often getting more healthcare information from social media, such as Facebook and Instagram, than their own providers. So like, how do we do it? And that's why we developed this process, where we thought about it in such a meaningful way, and we're like, this is an opportunity. This is a chance to create that digital gap and like close that divide, but thinking about it in a meticulous process.
And just real quick, I mean, when I speak to clients and we're talking about our, how we go about it here at mPulse, you got to hook the member. You got to cut through the noise. Or the patient, tell them, hey, you should need to pay attention to this text message. And the second piece, which I think, Shivani was sort of speaking to, is it's education. What's in it for them? Why should they do it? And people learn different ways, right? So for me just to have a block text in a text message, that might work for some, but not all. But we have digital pieces that we pull in. People learn from doing photonovellas, which is almost like a comic book stuff. We use Facebook story type of stuff, as we're going through progressing, everyone's familiar with. Those are the things that help educate people. And we do things, we use modality, or we do it through the cell phone, but we use things that they're already comfortable with. So like I said, the Instagram, Facebook stories, things like that to educate folks. And then the last step is to make it easy that Shivani called out earlier by including a phone number. What's the next step? Because I think if you educate people and you give them control, and when you speak to them with respect, you will get a result. And I think our data supports that time and time again, and we're only going to get better as we continue.
Great. Okay, next question here is, I see reduced ED visits. Do you have outcomes for ACH admissions for ambulatory care sensitive conditions?
So we have reducing ED admissions, yes. Now, I'm sorry, do we have data on?
Sure, I'll read it again here. It says, I see reduced ED visits. Do you have outcomes for ACH admissions for ambulatory care sensitive conditions?
Off the top of my head, I could say probably, but I don't have that data point. But whoever asked that question, definitely email me and I'll be happy to follow up with that information.
For sure, yeah, we'll do. Okay, next question here is, how does mPulse deal with the various languages of diverse populations? So like in Long Island,
Yeah.
For instance, there's a lot of populations in diverse cultures.
Yes. So that's actually one of my favorite things to pose to customers as I'm talking to them, especially when I know they're coming from a diverse region such as Long Island and New York City. I ask them, I'm like, so what does your member population look like? As I mentioned before, we can translate into 150 plus languages. Of course, we want to take into consideration the volume, right? If it's 1 or 2 people, we want to consider what that might look like. But if it's a couple hundred, if it's several thousand, then yeah, absolutely. A lot of our campaigns compulsory, we do English and Spanish because that's just the need of the landscape. But we have done so many languages from, as what you might expect with like Chinese, Mandarin Canto, all the way to Tagalog, Ilocano, like we can cover the gamut. It's about data, right? Like it's really important to have that data and information on the individual. If you don't have that, we of course offer solutions that can ask and connect with the patient and see what are their language preferences, but it's really about making sure we have good data first in order to ensure we're creating that meaningful connection.
And I will add on to that. We also have a nice, from a technology standpoint, we can start our message, an outreach in English, let's say. And then as they're reading that welcome message, it might say at the bottom of it, to receive this message in Spanish, type in reply ESP, right? And what happens is the rest of the campaign is in that language, so it would be in Spanish. And so we can do that for multiple languages. So to Shivani's point, like, if you have Cantonese or Mandarin or Korean or whatever it might be, as long as we know up front what those languages are, we embed that within our campaign. And then you don't necessarily need to know every single person what language they speak. And it's interesting, a lot of research that's been done, you have people that like might be new to the United States, and you might assume that they are Spanish speaking. They don't always go that route though. You want to give them the choice to say how they want to engage. You don't want to make that assumption a lot of times. And when you do that, again, you're giving control to the person on how they want to consume their information. And when you give them that control, you get better results. And so that language switch is really important and really cool technology.
And leveraging language is also an incredible important part of health literacy. To Christian's point, we should never make an assumption based on someone's last name, right? On like what language they want to speak. But we should always give them that opportunity to do that and make the decision for them, because there are plenty of people who can be multilingual in many languages, right? But there might be one singular language they're more comfortable and maybe like a native speaker in which they prefer to digest their health information. So providing that opportunity is incredibly empowering to the individual, and it treats them with compassion and without condescension. So I'm always a big fan of leveraging different languages for our programs.
Well, as our world gets smaller and smaller, that becomes more and more important, huh?
Mm-hmm. Absolutely.
Okay, our final question here is, it says, I agree a lot of people are in low trust mode. I have found that making and keeping commitments helps to build trust. How does mPulse Mobile go about making and keeping commitments with patient populations?
So I think, oh, go ahead, Christian. I want to hear what you have to say first.
Yeah. Well, I think when it comes to, that's a greite question. Because I think when it comes to making and keeping commitments, it mean a lot of different things. But I think most people, if you give them something and you make it easy for them, and then there's follow-up, there's a closed loop, there's something that happens, it's not, no one ever wants, I mean, for me, just if I ask someone, if I get asked a question, I try to respond to it, because I've been on the other side where I've asked a question and nothing happens, right? And so when you have that sort of that end piece of it, which is, following up, did you get your appointment? Did you have this? I think that maybe is something that we can sort of help along those lines, right? Because you never want to ask a question and not get answered. If you say that this is available at this time, then you want to make sure that you're basically able to go in and get the service you want at that time that you scheduled. I think along those lines we can help, but I'd like to learn more about what that commitment piece means to better answer it. So I don't know if that's a great answer or a terrible answer, so I'll stick it over to Lonnie.
Sure.
Yeah, I was thinking the same thing, because like when you're talking about like commitments and promises, I always wonder what that means. And I think it's kind of highly personalized to different practices and like who's running the care. From my experience as a consumer of healthcare, because friendly reminder, we're all consumers of healthcare, is that I want somebody who will treat me with respect and not scoff at, my questions. I did health communications in my master's, so I became very well equipped to try to understand how to take what providers and doctors are saying and put it in a way that's easier for individuals to digest. And when you ask clarifying questions, that shouldn't be met with a scoff, right, to me. So like that creates that trust. When I can go to a doctor, I can go to a provider, and they don't make me feel stupid for asking these questions. And, that's an incredibly important part, I think, to building the trust, especially if sometimes a patient comes to you with the most absurd question, right? Like, especially if someone has a cultural practice and belief that is something that you've never heard of, but that is something that is embedded within their own culture that they're believing can help improve their health. You don't want to laugh in their face, right? You want to be like, okay, like tell me more, and try to see if you can understand this better, to understand, because we also have to think about holistic healthcare when we're trying to build these relationships. And people are going to have their different, like their different salves, their different juices.
Sure.
And as long, like, we have to think about it and answer that with like accuracy, but also make sure we don't laugh in their face.
Yeah, no, that's a great answer. I know that one was kind of a nebulous question. Actually, we did have one more come in, and I think we've got time to handle it here. Uh, can you talk about outcomes you've seen specific to ED deflection? Curious about this and how you've incorporated health equity in for this use case.
So we have a lot of different we've run a number of different ED deflection campaigns, and there's a couple different flavors of it. We could talk generalized, to the entirety of the patient population, where the best places to go for care are. So don't go to the ED every time. If you have a cold, you can talk to your provider. You can call the 24/7 nurse advice line. You can do an online visit. So that's one bucket. Then you have another bucket where it's really like you have the frequent flyers, right? And those are the people that, whatever your definition of a frequent flyer is, multiple visits to the ED over the course of a month or a quarter or whatever it is. We have a different program that really focuses on that and uses to educate them. Within those programs, though, I think the beauty of it is, there's the ability to really define, what that program looks like based upon the makeup of the population of those that are going, through like an SDOH index, for example. So if we see some commonalities there, that program that we're going to roll out is going to be really hyper focused on those people and some of the equity issues that they have in their lives or might have in their lives. So when it comes to the results, we have a number of case studies. So I'm happy to share that out, Garrett. I don't know how best to get that to these folks, but depending upon which version that we ran and where it was run, I can we see results from anywhere from 8% to 40-50% of ER diversion, depending upon what it is. So
yeah, that's impressive.
And just to continue to add on to that, especially talking about the health equity lens in which how do we apply it. So kind of how I mentioned earlier, health deserts are common and they are a huge barrier. And that is often, like in some areas, that's why people are going to the ER, because they don't have access to primary care, urgent care centers. That's not necessarily something we can change. We can't bring physical locations. However, we can educate and we can improve their understanding of what resources are available to them. So like Christian said, calling the nurse line, or if they have internet that is available to them, telehealth. Telehealth can also be a valid option. And I know, like, I have one of those high-five visions next couple of years where I wish I could tell an ACO or teleplan, be like, this, if you have mobile health clinics, this might be a great opportunity to go to these communities because this is what we're seeing. And I think that would be a wonderful way to take action and look at that to drive that down. So again, it is thinking about the education, it's thinking about the access. People don't necessarily want to go to the ER just because, but then there are some people who do, right? Loneliness is very much a concern within the healthcare ecosystem of patients who are lonely, who just want human interaction. So how do we engage with them in a meaningful way and try to find community resources, community programs in which they can be engaged with individuals outside of their home perhaps, so then they feel less inclined to go to an ER and seek some type of personal human care.
I think that's a great point. Well, with that, we are going to wrap up for today. So I wanted to thank you both again for a wonderful presentation. This was awesome and covered a lot. As we close out, a couple things that I wanted to really quickly mention. I'd like to encourage you all to go by bbcexhibithall.com and check out the mPulse Mobile virtual booth that's over there. It's kind of like a snapshot of what they're doing in the value-based care space. There's a lot of resources, some videos, some things that you can drill down for a deeper dive, and you can connect with the team there as well. So go and check that out if you would. And then I wanted to also let you know about Activate 2023. And this is a small conference that is hosted by mPulse Mobile every year, and it is in Minneapolis, Minnesota, September 27th to 28th, and wanted to encourage, if you would like to attend, this year's theme is designing consumer journeys for health equity, and our keynote speaker is Ruha Benjamin. And I think it's going to be a really great opportunity to go. Now, we have just put out in the chat a link. Oh, maybe we didn't. Hold on. I'm going to put out a link in the chat here to everybody. And if you sign up for that, you actually will get a special bonus by being a part of today's session. And I'm going to put that in here as well. And I believe that the admission is comped completely for those who have attended today's session. So there is a special code there for that. And what we'll do too is when I send out the information afterwards with the slides, this slide will be in there, and that's a hot link to where it says visit the website, where you can actually go and register and find out a little bit more. So anyway, we would love to see you in Minneapolis. And then finally, if you would like to reach out to either of our speakers or to the mPulse Mobile team, their contact information is here. And they would love to answer your questions. If you would like to submit an RFP or just ask even general questions, feel free to do that. Or you can reach out to me, and I'm happy to facilitate an introduction and put you in touch with the right folks. So with that, I wanted to thank you all again so much for joining us today. I hope you have a wonderful rest of your days, and we'll see you on the next webinar. Bye now.
Thank
Thank you all.
you.